final plenary lecture of the 30th edition of the SSPH Plus Public Health Summer School. I am Suzanne Suggs, and I'm going to introduce to you just a few little things before I turn it over to my dear colleague, Carlo. So we've had 10 plenaries this week where we've welcomed 180 participants enrolled in courses coming from over 50 countries. And we've also had many other guests join us because, as you may know, the plenaries are open and free to the public to join. And we've had many people join as well. All of the plenaries have been filmed and will be and are available on the SSPH Plus YouTube channel. So if you didn't catch one that you'd like to see, please go and take a look there. You can listen and you can also share it with your colleagues. We'll keep those there for a long time. If you could please, in the chat, say hello to others on the session. Tell us where you're from and anything else you might want to share, but certainly tell us where you're coming from so we can say hello to each other in a virtual way. In this final plenary, we're going to be hearing about improving health systems efficiencies and equity in the role of health economics. But I'm going to let my colleague Carlo introduce that the session and the session speaker to you. What I'd like to do is give the final testimonials in our series of 30 years of public health teaching for the world, perspectives of past and current participants. So we have a colleague, Nargis, who comes from Tajikistan and who took courses in strategic project management and also economic evaluation, who sent us her testimonial. And one of the things I really appreciate about your testimonial, thank you so much for contributing, is that she shared with us a picture of the course. So when she took it back when we were able to offer the course in presence. This is the strategic project management course, and this is a small group of students in the larger class working on an activity hands-on. So she says, I feel honored, blessed, and grateful for the opportunity to get enrolled in the summer school in public health policy, economics, and management in Lugano, Switzerland. Both the strategic project management and the methodology and practical application of economic evaluation in healthcare courses that I attended were elaborative, interesting, and practical to my work needs. These courses enabled me to gain a wide range of skills and knowledge, which provided invaluable to my professional development. The summer school in Lugano is a unique platform for health professionals around the world to come together to share, interact, and learn from each other, to exchange expertise and experiences and inspire in an inspiring and stimulating environment. It brings us together, allowing us to strengthen the public health culture and to develop a broader understanding of the economic, managerial, and policy challenges in our countries. I believe that these courses contributed a lot for my personal professional growth that enables me, working as a public health specialist in my home country, to contribute to ensuring better health and more equitable health systems in Tajikistan. I wish and thank all the organizers and experts who supported this annual event, making possible for us to attend and benefit from this opportunity. I thank you very much for your words, and we do take this seriously. We hope that everybody who's been following the courses this week is also sharing in this mutual learning for change experience, and we do look forward to next edition, to expanding this to in-presence, hybrid, and also online learning. Now I'd like to introduce my dear colleague, Carlo Di Pietro. He is a professor of healthcare management at SUPSI here in Ticino, Switzerland. And not only is he a good colleague, but he's also a former course participant. Carlo followed courses in 2005, 2007, and 2008. He attended plenaries in multiple years. And really important and exciting for me to share with you now is that he is now a member of the steering committee of the summer school. Carlo, I'd like to hear a few words from you about your experiences and thoughts for the summer school, and then I'll leave it to you to turn it over for the plenary talk. Thank you.
Thank you very, very much, Suzanne, and welcome to everybody. Again, my name is Carlo, as you see on the picture. Now my beard is a little bit more white because I'm getting older. Yes, you told the truth. I was attending courses in 2005, 7, 8. I was almost addicted to the Lugano summer school, but it was not yet Lugano because it was all in Ascona, just another little town of our wonderful Cantone Ticino, here in the Italian-speaking part of Switzerland. And there were courses taught both in French and in English. And I was curious. This is why I enrolled. I had already my beautiful job. I had not, I would say, I was not seeking a career, but I wanted to know people, but above all, to listen at people that could give me a different perspective. And this is why, as an economist, I was attending most courses taught by medical doctors in public health, of course, but with a different perspective. So I had courses about the evolution of health services taught by our former dean of the Swiss School of Public Health, Professor Fred Paccot, based in Lausanne. But I also was attending a course on equity, something that also our colleague Joachim Marti, the speaker of tonight's plenary session, will talk about. And so it was health, the title was Health, Poverty and the Social Inequalities, taught by a professor that worked in Geneva. And then yes, as an economist, but an economist very much interested in health services, how the services are organized and how they do provide real services to people. I was attending a short course taught by an American guy, an American professor, on health services organization and research. My last two courses were one in health planning and management, taught from another very important person for the Swiss School of Public Health, based in Basel, Professor Marcel Tanner. And the last but not least, of course, course that I attended was on a topic, that is much closer to my colleague Suzanne, social marketing, marketing social, for serving to healthcare and serving the health, taught by a professor, François Lagarde, that was based in Montreal, in Canada. So as you see, different topics because yes, I was very curious, and this is of course an important part of my previous education. I attended many other courses, to be honest, but there was a wonderful setting. It was in presence. I made wonderful friendships also with people that works still now in Ticino. I strengthened my network in the French-speaking part of Switzerland. And I also had some wine at night. I remember wonderful aperos with people from Crimea, with a Crimea wine that is very, very good, and other anecdotal fact that I will reserve for my own. So I close this very personal part, and I assume a more formal role in introducing you Professor Joachim Marti. Joachim Marti and myself, we are two economists. So usually this is the first questions of Joachim Marti will be on that. Economics is very important, of course, but I think that the best for health economists is to remain humble, to know that we have to serve other objectives and other dimensions that are not the economical one or the economic one. So I'm very pleased to introduce Joachim Marti. He is a professor, associate professor at University of Lausanne, in a center, in a university center that has put together the family medicine and the public health. There is head of the research for health economics, and this is why I switched to him, and I introduce him as our final speaker of this nice, wonderful, I would say, series of plenary sessions. Up to you, Joachim, and thank you very much.
Thank you so much, Suzanne and Carlo, for the introduction. And hi, everyone. It's a real pleasure to be here. I see some people are next door in the office. Some people are in Albania, Myanmar, Ukraine, all over Switzerland. So it's a real pleasure and honor to be here for this last plenary session, in which I'm going to try to give you one definition of health economics, give you some historical perspective on the discipline, and also try to share a few thoughts about how it could influence and inform health policy. So maybe a first step is to discuss a few myths around health economics. And I will try to challenge these myths during the presentation. And the first myth is that everything we do is about cutting cost, reducing cost, looking for savings, rationing. Whereas we're more interested in resource allocation, trade-offs, value. And it's more about rationalization of the use of resources rather than rationing. Of course, rationing is sometimes useful in systems, as there is, and there might be some economic justification for rationing, but it is not all what we do. And maybe the second myth is that there is some misconception that health economics is a synonym for economic evaluation. And you've probably, learned something about economic evaluation during the summer school or in previous courses. It's a very important subfield of health economics. It's growing. It's probably underused in informing policy, including in Switzerland, but it's not everything that we do. So I will try to give you an overview of other things that economists and health economists do. And finally, maybe a more conceptual thing is that often a myth is that efficiency is a goal of the health systems, whereas in fact, efficiency is probably not a goal per se of health systems. Goals of health systems include improving health of the population, ensuring a fair distribution of health in the population, and you can achieve these goals more or less efficiently. So I will go in more details about this aspect at the end of the talk. And maybe to start with, I think a good first step is to, before defining health economics, is to define what is economics. And this is a very difficult question, as you can see in the first line here. This is the first sentence of an article, a review article that tried to answer this question, what is economics, in the Journal of Economic Perspective. And in fact, economists don't really agree on what is economics. So it's a very complex question. And I've picked two definitions. One is more philosophical, is the one from Keynes in 1922, that tells you that economics, in fact, is not a magical tool that will give you policy implementable answers immediately, but it's more a way of thinking, a way of approaching problems, a way of combining theory and empirics to better understand relationships between agents and systems. And the third one is a more pragmatic definition of economics, which in fact tells us that we are interested in decision-making and choices in the situation of limited resources. And these choices can come from individuals, business, companies, governments, or the society as a whole. So this is really what we're trying to do, better understand choices in this specific situation of constraint and limited resources. And maybe a first step towards health economics from economics is realizing that healthcare and health are not conventional economic good. And a way to represent a conventional economic good or market is this one, where on the left you have buyers, that's the demand. On the right, you have sellers, that's the supply. And goods and services are exchanged with money, and the market is efficient. Price reflects value and quality of the goods, and everybody is happy, and it's simple. And as you might expect, healthcare is very far from this, perfectly competitive and well-functioning market, and for many reasons. And I list here a few of these reasons. Of course, one very important aspect of health and healthcare is uncertainty. There is a lot of uncertainty in when you will become sick and if you will become sick, and what's the consequences of sickness for your quality of life, for your finances. What's the efficacy of treatments? There's a lot of uncertainty around that too. Another type of issues in the healthcare market is the imbalance in who knows what, if you like. Meaning that, for instance, providers and doctors know more than you about what is efficacious as a treatment. And this gives rise to the fact that a lot of the demand for healthcare is in fact strongly driven by suppliers of healthcare. And this is a very specific aspect of the healthcare market. Also, there is an imbalance between what individuals know about their health, what you know about your health, and what the insurer knows about your health. And this creates also tensions in the insurance market. Perhaps one aspect of health and healthcare that is especially interesting for you and for a kind of a public health audience is the notion of externalities. Externalities means that there are some goods and services for which the costs and benefits to others, so the societal cost and benefits of these goods and services are not reflected in the price that people pay for these services. Let me give you an example. For instance, vaccination. People might decide whether or not to vaccinate on an individual cost-benefit calculation, and perhaps the cost and benefits of vaccination that accrues to others and to the society is not taken into account in this decision, or not enough taken into account in this decision, which gives rise to perhaps under or over provision of these goods. And if you combine all these specific features of health and healthcare, there is an idea that healthcare is what we call a merit good. So as we've shown, there is a lot of information failure in terms of what you could expect in terms of benefits when you decide to consume some healthcare. And there is a long time lag between the moment you consume healthcare and when you get the benefits from the treatments, and of course, strong externalities. And this gives rise to situations that if you let the market drive health and healthcare, then you might probably have an under provision of healthcare. So you need government intervention to correct these things. And another justification for government intervention is that probably the free market would not give rise to a fair distribution of health in the society. So that's another justification for government interventions, trying to achieve not only an efficient functioning of the system, but also equity in the distribution of health in the society. And basically this role and importance of public regulation, government intervention in the system that is justified by everything that we've just seen gives rise to a very complex organization of systems where you have to pool resources from the populations through taxes or insurance premiums. And then, the payers that pool resources have to pay providers following certain rules. And then you have, of course, access rules, who can access care and what conditions do we have to pay for care or not. So this gives rise to a whole set of problems, of issues. Government regulation don't solve everything. There is no magic bullet, but it tells you that it's a very complex area. And this is where I really join what Carlo said. We have to be humble as health economists. And I really like this sentence from Tony Collier in 1971 that really says that there is no magic bullet again in health economics. We have to work. Everything is an empirical question, and we cannot really say which institutional arrangements or which type of healthcare system will be able to correct all these externalities and achieve efficiently the goals of health system, which is to improve population health and ensure a fair distribution of health in the society. So our job is really to pursue step-by-step small empirical questions, try to apply systematically tools of economic evaluation like cost-benefit, cost-effectiveness analysis to improve allocation of resources, apply theory and empirics, econometrics, as we say, to better understand the supply and demand of healthcare and their interactions, and also take one step back to analyze what institutional arrangements are more able to achieve this or that goal in the system. So it's really a step-by-step approach that involves a lot of empirics, some theory, and a whole set of tools that I will come back to later. And one definition of health economics is one that I like quite well in the book about health economics. Is the application of economic theory, models, and empirical techniques. So it's really what we're working with to the analysis of decision making by individuals, healthcare providers, and government. And this is really the summary of what we just talked about. And the toolkit for that, what we are using to do health economics, you have, and there are publications with theoretical models to understand behaviors by these agents. This is less and less the case, but there's still are strong theoretical contribution in the health economics literature. We do a lot of positive analysis about describing healthcare utilization, cost, how financing mechanisms work, and so on. And also we use a lot of rigorous empirical methods to identify causal impact of health policies and interventions, and also rigorous empirical methods to assess and measure the value of health interventions and policies. And this is what we are working with. And maybe we can take a few step backs on the origins of the discipline. And of course, you can trace back health economics in the early 20th century, but I chose here three main steps in the evolution of the discipline. And the first one is, it's quite theoretical. It's how people started to introduce health, the role of health and the value of health in economic thinking, economic theory, and economic analysis. And these are contributions of scholars from the Chicago School that started to think about health as an investment. So in fact, you have a health capital in which you can invest, and this health capital depreciates over time. And one of the conclusion or a take-home message of that is that health is both what we call a consumption commodity. So it has direct value. Health per se has some value, but also it allows you to be, for instance, productive on the market. So it has an indirect value. So this is I would say, a first theoretical, very important contribution of economics to that allowed to evolve towards health economics. And a second one that is also key in the development of the discipline is, of course, what we discussed earlier, is the recognition that health and healthcare are not conventional commodities, and that uncertainty and imperfect information are really important and have strong implication for the analysis and regulation of healthcare. And this is a seminal paper from Kenneth Harrow, published in 1963 in the American Economic Review, Uncertainty and the Welfare Economics of Medical Care. So started with theoretical contribution, how to think about theoretically about health in economics thinking, and then move towards the recognition of the peculiarities of health and healthcare, and why, and what implication does this have for regulation, and then finally move towards more societal views of health and the role of healthcare, and also thinking around health policies and health policy analysis, and how economics can contribute to health policy analysis. And this is a very, very dense and important book by Victor Fuchs, which has made many contributions to the discipline. And here I just summarize four conclusions that was drawn from the book review published in the 70s that are still very relevant today. So that was kind of a summary of thinking that happened in the 70s, but that are really still relevant today. And the first one is that, in fact, medical care has only a marginal contribution to life expectancy, and that there is a huge importance of health behaviors and other social determinants of health. So medical care is only one part of the equation. The second one is that we have considerable room for improving what we call technical efficiency. So how do we combine production factors to achieve efficient production of healthcare? And this has also resonance today. How do we combine different skill set to achieve the production of healthcare? Do we use or involve more nurses in some of the production that was initially more under the responsibility of doctors on these kind of questions. How do you combine these production factors better to achieve an efficient production? Then a third really important contribution of this book is that we tend to have on the market, and still today, I think it's still true, an excess supply of very sophisticated high-tech services and some under provision of first-line services. So we have healthcare systems, and many healthcare systems are really centered on acute care hospitals, maybe sometimes at the expenses of more first-line services, primary care and public health in particular. And finally, and this is also related to this strong relationship between the demand and the supply that we discussed earlier, there is this dominance of providers as the key decision maker in the production of medical services. And this emphasizes again that there is a strong influence of the suppliers in the demand for health and healthcare. And so after reviewing these three contributions, we can have a view on what is health economics today. And there is one way to look at this is to see what are the contributions, where are they published. And I think in this spectrum, it's a bit schematical, but you have on the left the medical journals that publish predominantly HTA and economic evaluation studies, not only, but mostly. And on the right, you have economics journal. And some tendency that we observed these recent years is that more and more general economics journal, this means not economics journal that are solely about health economics, but general health interest economic journals publish more and more empirical and theoretical health economic studies. And there is a clear trend into that. John Gruber has summarized that in an article recently that shows that some of the top empirical economics journal publish about 1 in 8 of their articles in health economics. So it's a very important field, not only for the medical profession, but also for the economics profession. And some of the recent trends that we can observe, there are many of them, but I just picked two. One is the importance of equity in the debate. And then there is a growing literature on the departures from the rational consumer and the neoclassical model with the development of what we call behavioral economics. So these are two examples of trends that we can observe in the discipline. Of course, there are many contributions of health economics. Some of them are related to the impact of insurance coverage on healthcare use and financial protection. These are two very interesting studies if you have the time to look at them. One is a randomized control trial of insurance. So they randomly allocated insurance plans to people to see how they reacted to this price change. And the second one is a natural experiment where actually health insurance was allocated based on a lottery in Oregon. So health economists exploited that to better understand how people react to prices on healthcare markets and whether they increase or decrease their consumption in response to price change. There is also a whole strand of the literature that is interested in the consequences of cost sharing. So we can justify cost sharing because we think that people have to pay something for their care, but this might have unintended consequences. And there is a whole strand of literature about that. Of course, the economists also looked at what we call provider incentives, so how providers react to the way we're paying them for the care they deliver. There's a whole literature on that. An interesting literature on the economics of prevention, more on the individual level with Kenkel in 1994, how people think about prevention, how do they decide to invest in prevention, and Newhouse, a very recent paper that go again one step back and see how prevention is considered in health system versus care, and whether there are imbalances in how we allocate resources between care and prevention in systems, and what are the tools that we might use to improve that allocation. And also what is a growing field, as I said, topic is interest is the extent to which health is equitably distributed in the society. So inequality and inequity are very important and growing topics. And there is a very nice summary chapter in the Oxford Encyclopedia for Health Economics published in 2019 that would give you an overview of how economists think about inequality and inequity. And finally, of course, a lot of contribution, as I said, of economic evaluation in the broad sense. So identification and measurement of waste in the system, cost of illness studies, burden of disease studies, so on and so forth. So it's much broader, but these are really some of the contributions that I wanted to underline, and you have the references at the end of the presentation, of course. And one thing with economic evaluation is that there is this idea of we want to reach efficient resource allocation. There is the pursuit of efficiency, which is one of the goals of the system. And what is efficiency is getting more value from limited resources. And the thing is that in practice, when we think about how economic evaluation has been used in health system and policy making, it's often used to identify the value of a relative small number of treatments and at the margin, meaning that we have been and we have observed an evolution in the number of countries that use economic evaluation in their decisions to reimburse treatment and to implement some policies. But, and this is an important step, but to date, there's not been a lot of evidence that it had allowed to really strongly improve efficiency in how health system work. So there is a lack of this investment strategy of low value intervention. This is one typical example where health economics and economic evaluation could be making a stronger contribution to the efficient allocation of resources, would be to identify more systematically low value services and have strategies to disinvest in these low value services and reinvest in services that would provide more health to the population. And that's the notion of opportunity cost. So it's a growing field. It's more and more used in decision making across the world, but its impact is, or the proof of its impact is still lacking now. That's one of the take-home message that we can have if we look back at the development of HTA and economic evaluation. And beyond efficiency, I think one thing that we might and we should try to achieve in health systems is not only improving the level of health, which is one of the fundamental goals of health system, but also ensuring its fair distribution. And what is a fair distribution of health in the society? This is, subject to debate, of course. So you can have an equal distribution of resources in the system, which would be illustrated by the picture on the left, where everybody received the same amount of care. But what equity is really that for people who have more need, then you would allocate more resources. And this is illustrated by the different size of the box on the right. You allocate more resources to groups or individuals that are in more needs. And then you might have an unequal repartition or distribution of resources, but that could be seen as an equitable distribution of resources. And that's a fine and a subtle difference that we have to take into account when we think about how we allocate resources in the system. And some people say that if we want to improve equity in the system, it has to come at the expense of efficiency, and that there is an efficiency and equity trade-off. If you improve efficiency, this will deteriorate equity and vice versa. But in fact, what is important to understand, I think, is that efficiency shouldn't be an outcome of a health system. As I said in the beginning, it's really a functional relationship between what you put in the system, health expenditures, for instance, and what you get from the system, which are outputs. And these outputs can be, of course, improvement of health gains, but it also should be the distribution of health gains. And efficiency is really whether or not you achieve these goals with the right allocation of resources. And there is also a very important literature around efficiency and equity that is evolving in the economics and economic evaluation field. This is an example of a very nice contribution by Richard Cookson and his colleagues that really makes explicit this tension between cost effectiveness and equity impact of interventions and policies, and that we have to think about these two lines when we consider new treatments, new intervention. And you might have, in the best case, win-win interventions where cost effectiveness is improved, so efficiency is observed, but also equity is improved with these interventions. There is an example of vaccination here that is cost effective. There's a lot of evidence for that, but also reduces the gap in health between socioeconomic groups, for instance. And you might have also examples of lose-lose solutions where you have not or uncost effective or low value service that might also harm equity. And there is one example in the paper of very high cost hospital treatments in low resources settings. So it's probably not cost effective to do that. And in addition, it harms equity because the access to the high hospital is poor for some section and groups of the population. So I think it's important not only to think about the conventional relationship between cost and outcomes as we do in economic evaluation, but also, and I find this very useful, to always think about not only the cost effectiveness of treatment interventions, but also the potential equity and distributional impacts of these interventions and policies. And of course, I don't want to spend too much time about COVID. You probably discussed a lot also on the economic perspective around COVID, but just a few things that as health economics we can say about this pandemic. It has really highlighted the importance of well-funded and resilient health systems. And also I think one very important thing is that it shows that protecting population health and the economy are not conflicting goals. So there's been a debate at the beginning that we had to decide between protecting health and protecting the economy, but in fact we can do both. And I think protecting health also allows you to protect the economy. And it's been seen in several countries where we don't see actual relationship as would be expected between countries that did protect their economy and with strong impact on health. And if you look at the graph on the right, you are able, by protecting the health of your population, also to protect the impact of the pandemic on the economy. And the last thing that the pandemic has shown is it has highlighted and magnified the existing health inequities in the system, both within countries, so between population groups and socioeconomic groups within countries, but also, and more importantly, sometimes between countries. And this can be illustrated, for instance, by the inequitable allocation of vaccination resources across the globe, which have some very strong economic, short-term and long-term economic implications. And just a few examples of economic studies around the COVID-19 pandemic. Of course, a lot of publications are around the value of treatments, the value of vaccination, of testing strategies. There are some interesting studies about the trade-off that the population make between public health gain and the protection measures that are implemented, and more examples of interesting studies. And I just wanted to show you this overview, and you can look at the link here that summarize a little bit what are the contribution to date of health economics in the COVID-19 pandemic. And the summary is that a lot of studies have concentrated on macroeconomic impacts, on economic evaluation of treatment and vaccination and so on. And I've described the impact of equity of the pandemic. And these are the main three groups of contributions that were observed, but also what they raise is that there is a strong geographic bias towards a limited set of countries. So all this evidence, the vast majority of this evidence is concentrated in 5-6 countries. So there is a need for more evidence in low and middle income country settings about the macroeconomic impact of the crisis, the economic evaluation of the strategies that were adopted, and also the equity impact of the pandemic. And they also raise the fact that there is a lack of paper on the health financing implication of the pandemic, and also cost effect in the studies to better understand what are the economic application of COVID and perhaps long COVID and so on for health system and resource use. So briefly coming back to the myth that we discussed at the beginning of the presentation. So I hope you are now convinced that health economics is not only about reducing costs and looking at savings in the system, that health economists do other things, that economic evaluation is key, is important. Maybe its impact is not exploited as much as it could be, but it is not all what health economists do. And that efficiency is not a health system goal per se, but we have first to define what are the goals of the system, improving health, improving the distribution of health in the population. And these can be achieved with more or less efficiency. And if these three messages are, went through, it's already very good. Thanks very much for your listening, and I'm very happy to take questions now. Thank you.
Thank you very, very much, Joachim. I think you gave, yes, a really rich overview of health economics and of the added value of health economics to the challenges of today and to the future. We have thank you also for having kept the time. So we have some minutes, quite enough, for comments, for questions. And as Joachim Marti already said, references for his presentation are present on the slides, the last slide. So if there is someone that is interested in, let's say, going back to the original sources, you have this list of references. So I would like to open the floor to everybody. And there is the chat here in Zoom that give you the opportunity to ask questions, or the section questions and answers, the same. So we leave 1 minute to think about and to break these maybe we leave you some minutes to think about and to ask questions to Professor Marti. For the moment, I see in the question and answer section, thank you for the presentation. Could you give us a reflection about the case of Peru, which looks like an outlier in the graph you presented? It's always risky to present graphs, but I leave Joachim to comment on it if he has some news. Because
I know Peru has been hit very strongly in terms of health inequality. Obviously, if someone else has some ideas of why it is the case, I don't have enough information to answer that. But we know that its handling of probably the public health handling of the pandemic was not the best, and there's strong inequalities within the country, as it is the case in the region in general, and that has led to a strong economic impact too. But what would be interesting here is to compare countries from the same regions, and I don't think in the graph I showed you have many other South American countries. But so that would be a first step, is to compare what happened in the region and maybe in countries with similar population profiles. But I don't have a definitive answer on that. Maybe Carlo, you have some hints. So.
No, not at all. I realized there was an outlier, but I did not have other explanations. Of course, outliers usually, let's say, leave an alarm, but then they have to be analyzed in depth, because of course also this kind of graphs can be biased because of quality of data or other, also if they are well done. But in general, the message that that graph gave is that there is not a strong correlation about protecting, or a strong trade-off between protecting the health of the population and protecting the economy. This is the general message that I can, of course, confirm. But thank you very much, however, for this question. If you have other comments or question, we leave you some time in order to write on the chat. Thank you. Well, I don't know if other participants can, let's say, see what there is in the question and answers section. So I go on with reading them. And there is Arlinda Seu that says health investment is a long-term investment shared with many sectors, but when talking to policymakers, yet the money going for the health sector is low in many countries. Albania is only almost 3% of GDP devoted to healthcare. How can we approach policymakers to make them invest more on this sector? This is a question that I pass through to Joachim, because it's our
yeah, you probably also have your ideas, but I think it's a key question with the short-termism of many policymakers, where of course the benefits of investing in health and public health and access to healthcare will only accrue in the long term. So whether or not you can increase your chance of being reelected by investing in this with only benefits coming in the future is really a key question, and that might also drive underinvestment. And a way to approach policymakers is to explain, I think, this relationship between investing in health and the impact that it can have on the economy. So if you invest in intelligently and wisely in health and protecting health of the population, you might also have a more productive population, and you might have also short-term economic benefits. And these might be arguments that policymakers might want to understand, is that it's not only investing in health just for the purpose of improving health of the population, but it has all other side effects and positive benefits for them.
Yes, of course, if I can add, the healthcare is a labor-intensive sector, so it is also something that gives, that help the development of the society as a whole, not only the healthcare, as Joachim correctly said. We wait for other questions or comments. I invite everybody to share their comments. Just a few minutes.
Yeah, and if you are too shy or too tired, that's not a problem. You can also write me directly if you like. I'm just putting my email. If you're interested in any of the resources or the publication I put or some of the current research, very happy to take emails or share anything with you.
Okay. So I don't know, because I'm not I would ask if Susanne Sachs, she's the dean of the school. I think I really appreciated very, very much as an economist this presentation asked to Joachim. And I don't know if there are other comments. I see an hand by Razan Baki.
Yes,
But Suzanne, how can we do?
I've just given Razan an opportunity to speak, so
Yes.
you just ask your question directly.
Okay, thank you. A very quick comment from the point of view of the impact of COVID on economics. I enjoyed that part, but there is one maybe concern that I didn't see coming, is that the attention that we pay to the long-term health and economics in many countries is somehow underlined. For example, in many countries, they thought of short-run economic recovery, and they lost the health part. And in some other countries, it has been vice versa. I think the balance and the longer-term vision has been missing in many countries, and it's very important to echo on this aspect of the impact of the pandemic or any kind of epidemics on the economic, that the short-term impact might cause longer-term damage that will be difficult to recover from. Thank you. Over to you.
Yeah, thank you very much, Rosanna. I think it's a very good point. The graph I showed is really short term because we're in the middle of it and we need some distance. And it might well be that there is some relationship that creates when we think about the long term, it's not only long term, direct health effects of the pandemic, but it's also probably the long term health effects of the policies to fight a pandemic, like mental health issues and so on. So you're perfectly right. I think this relationship between the long-term economic hit of countries and also the distribution of this hit, because it's not equally distributed. When you think about economic recovery, you've probably heard about these different shapes of the recovery, and there could be a V recovery where there's a bump and we rapidly reach the level that we had before the pandemic. But in many cases, this is what some people would call a K recovery, meaning that for some groups of the population, there is a strong recovery, but from others, it's very difficult. And I think that beyond this graph that I showed, I think things will change over time when, exactly as you say, we take a long-term perspective on health and economic impact, but also it would be interesting to put an equity perspective behind it to see whether it has differently impacted subgroups of the population. So yeah, thanks very much for the comment.
Thank you very much. I shared with everybody the email address of Professor Marti, because he sent us he sent it only to a little the little group of the organizers. So I shared it. As he said, you can also contact him directly. I wait for the very last question or remark. And then we will close. I see that there are several comments thanking Professor Marti for his presentation. And I hope that was a good occasion to understand how economics can help with this humble attitude, as we said. But also Joachim Marti said how, let's say, how young health economics is, because it has been developed for the last 90 years or like that, and it's something that will go on, of course, in a very complex sector, the healthcare, and with a different, as we said, different objectives in terms of effectiveness, but also efficiency, but also equity. So I just give a look, I check the last comments. Thank you indeed for the great presentation. Thank you for the interesting presentation. So thank you very much for the overview you gave us with the new emphasis on equity. And I think there are not specific questions. So I thank you again, everybody. And I thank especially Professor Marti. I give the floor to Susan Sachs if she wants to say the last words. And thank you very much, and goodbye. let's meet again at Lugano Summer School in 2022.
Thank you very much. And before I take the last word and wish everybody a good weekend and a last final day of the courses for those who are following courses, we do have another question that's come into the Q&A. So I'll go ahead and take that, Carlo. No worries. This is coming from Erin, a former student of mine in social marketing who's now working at Sight and Life. And she asks, aside from the element of economic benefits, what are other ways in which policymakers can push for more transparent and equitable policy decisions?
Yeah, that's true that, you know, the argument of economic benefits is one currency that people like to speak with and that, you know, resonates to many policymakers, but there might be other ways. But is there the role of policymaker to push for more transparent and equitable policy decision? Or is it, you know, how the system is organized and how, you know, regulation is organized that will give rise to a more transparent and equitable policy process? And I think that's a very tricky question. Is if I think about, you know, Switzerland, for instance, with the complexity in which the system is organized, with the different levels of decision making, it's very difficult, even in a system that is a very strong democracy, to understand us as health policy analysts, how things work and how decisions are made and what's the influence of lobbies and so on. So I think even you know, pure or strong and well-functioning democracy, for instance, is not a magic bullet again that will solve this issue of transparency. So I think it's really has to do with the values of, you know, what objectives do we have for our system and whether we are able to fight for these objectives. I don't know if I understood the questions very, very precisely. I don't know, Carlo or Susan, if you have any thoughts on that.
No, I have not particular thoughts. Maybe, of course, sometimes, sorry if I say so directly, but sometimes economic factor can be oriented in order to improve equity, but also transparency. For instance, we can set some incentives or some fines if you have not if you are not transparent enough as a provider. But I agree with Joachim that this is not everything doesn't go together because we have quite effective systems that, however, are not so transparent. Good example for it is in Switzerland, but also because of this institutional complexity of a federal state with this tradition of privacy and of lack of information. Public information is not so much. And also the history of the system itself, quite liberal, without, let's say, a strong, unique national system, but bottom-up, a system that has been developing a bottom-up with a lot of differences in provision and also in institutional arrangements. So yes, but sometimes we use the carrot incentive, so the economic incentives, in order to improve the transparency. It doesn't work so much. It doesn't work always, but this is a way to improve the system. That was the only remark that I can add.
I think that was very
Thanks,
well
Carlo.
said. Yeah, thank you both. Thank you both very much. Joachim, thank you so much for this excellent presentation. Incredibly clear, incredibly focused, and well communicated. You know, economists aren't known for being the best communicators in the world, but you're fantastic. I would love to be a student in your courses. And just a little shout out to those of you who may not know that Joachim is also on the academic board for the PhD program for the Swiss School of Public Health, in addition to his professorship. So yes, I would be very, very happy for all of my students, including myself, to come take your courses.
Thanks so much,
very
Susan.
much for this excellent final lecture. Carlo, do you have something to say? Oh, no.
I want to say hello to everybody and goodbye. See you next year.
Yes. See you all
Thank you
next
very
year.
much.
And keep tuned to the website of the Lugano Summer School. We'll be updating information there about the next program. And for all of those who followed courses, you'll be getting a course evaluation soon too. We hope you can fill that out and help shape the next summer school and next summer schools. We have no end in sight, that's for sure. Public health challenges are telling us that we have to keep doing this for a while. But I'm very confident as we have good capacity building and mutual learning for change happening every year, and we'll continue to do so. Thank you all very much. Have a good rest of day and a great weekend.
Bye.
Grazie.